Dear Dr. Hardinder Singh Bedi, thank you for this initiative with Master Series for the awareness of phlebology. This is my heart topic and this is very important for me too. I am Erika Mendoza. I am general practitioner from Germany, which chose to learn phlebology lots of years ago and specialized then on duplex ultrasound of superficial leg veins. And I'm very happy to be the General Secretary of the German Society currently and the president of the meeting this year, which will be held in Hanover. And already now, but at the end, of course, again, I invite everybody to participate very, very happily in Germany here with us. But we will do it also streamed with an English, completely simultaneous translated path, 3 days. And so perhaps somebody of your wonderful country can join in. Choosing wisely, why do we need new concepts in medicine or in phlebology? I mean, we have evidence-based medicine, we have Cochrane reviews, we have national and international guidelines, then we have recommendations from our hospitals or from the healthcare insurances. But if we put the hand on the heart, do we really know everything in medicine or in phlebology? I don't think so. Now let's have a look what we are talking about varicose veins. I know you have had very interesting sessions on this topic. I will try to make a little bit of statistics of the thing, why it is so important. And in Germany, we did a review about the population. This was done by Eberhard Rabe and Felicitas Panier, very important phlebologists from Germany, and they took the population, 20,000 persons, living 10,000 in a city, 10,000 on the countryside, older than 18 years, adults, and they looked if they had spider veins or varicose veins or edema or skin changes, ulcerations of the legs or past ulcerations, which is this classification, CIAP, and they stratified the population according to these findings. So we have to know that varicose veins are extremely prevalent. If you see all these people have some kind of varicose veins, and so this illness is really prevalent, at least in Western countries. So who is in need of treatment? We can't treat everybody just because there is a little spider vein. And who will benefit from a treatment? This is the important question. And if you see the high prevalence of this illness, you see how important it is to sort out. Only 10% are free of any sign or symptom of varicose or venous disease. And as I told, we can't go ahead and treat 90% of the adult population. This makes no sense. Just to show a little bit what we're talking about, these are spider veins and reticular veins. This is C1, and we have 60% of the German population having at least one spider at any point of the leg. And this means that if they claim to be treated, we have a lot of work to do. So 40.3% have C2, which is some kind of visible tributary larger than 3 millimeters in diameter. Still, they are C2 because they have no edema, they have no skin changes, they have no ulceration. Perhaps the illness degree is not so high. And summing C1 and C2, we see that 75% of the adult population has visible veins without signs of skin damage. And so nobody knows how long it takes these patients to go on a next step of the disease. We have some studies about evolution from the beginning of the edema when people come to waiting lists for surgery. But in these stages, C1 and C2, we have no evolution data. C3, this is edema. You can put a finger in and it remains. This is also C4 because it is skin changes. And I personally think that it is very seldom to find patients with edema and no skin changes. Edema due to varicose veins, of course. With edema due to other reasons, you find lots of them. But due to varicose veins, like in this leg, you see this leg is larger than the other one. And here you have your varicose vein and you have this pitting edema. This is 13.4% of the population. And we know from a study of England, when these people are put on waiting list and it takes 2 or 3 years to get operated, the disease has developed in these 2 or 3 years. And then we have the really strong affection of the skin, which is in 3% skin discoloration, in 0.6% people that had an ulcer, and 0.1% in Germany people with an active ulceration. This means 3.6% of the population had severe consequences of chronic disease. Like this is the scar of a past ulceration, like these skin changes, either very localized or large, as the patient we already knew. And of course, I show it not so horrible. I'm sure you have seen larger ulcers in lots of patients. This is one already healing. And this is not good for the patients. Of course, we have to aim to avoid this situation by all means of our treatments. And this means 0.1% is still 60,000 persons in Germany. And I'm sure that in other countries where the heat is higher and the humidity and the standing work places, standing or sitting, are more often used and so on. I think in other countries the ulcerations are much more frequent. So we complicate the thing a little bit more. Depending on the income and the country's structure and culture of the people, this lady will be dying because she thinks with this she can't move out on the street, or she will even ignore it because she has other problems, how to feed the children, for example. So we all know this is really not a clinical issue. It's just like gray hair. We have it when we grow older. But some ladies really suffer if they have this. So we always have to be aware that we are comparing really very different cultures and situations. Again, depending on the income and country, this person will not go to the doctor because he doesn't feel anything. Lots of people with this appearance of the skin suddenly come because the wife sends them, or they have an ulceration and they say, no, I've never noticed that my leg was brown or discolored. And really, this doesn't happen in 2 weeks. This happens along years and years where you didn't even give a damn on what is happening with your legs. And this is also a situation, if you have a lot of things in brain, you have to work here and run and do because you have to feed your family, you have to care for somebody, you have other problems, you have other illnesses much more important, and you don't have the money to pay the doctor, you won't go to the doctor with this problem. So we really have to have in mind that varicose disease depends very much on the status you have and on your income and on your problems. Of course, this person notices that there is a problem because it starts stinking or liquid comes out. And of course, lots of them, and if you look in Germany, 45, 50 years ago, this was fate. Women with 3 or 4 or 6 or 10 pregnancies had at least one thrombosis in one of them, and they have this, and this is normal, and they every morning they put the bandages on it. This is also here in Germany the reality from 40, 50 years ago. And it was 6% of prevalence in the 60s. And now we reduce it to 0.1%. This is a good evolution of healthcare. In Germany, we pay a lot for healthcare, and everybody has the right in Germany without paying anything to get this treated and to get compression stocking. So you just to remember, we have to compare and we have to be aware of which countries we are talking about, and if this produces shame to go to the doctor and tell what's happening there. So again, what are we talking about? We have a disease affecting the vast majority of adults in industrial countries. We have no idea of which treatment in each setting of the countries have the best outcome. Doing nothing, wait and see, giving compression, doing surgery, doing sclerotherapy, doing endovenous treatment. We don't know the combination about highest satisfaction and lowest recurrence rate. We even have no idea when to start treating 75% of the population affected by varicose veins. You remember, 10% had nothing. 75% had little or medium varicose veins without skin changes, and then 15% had edema, skin changes and ulceration. And on the other hand, we have doctors as entrepreneurs or clinics as industries that need to earn money. And we have the situation that we have to have a balance between what the patient needs, what the insurances are able to pay, and what the doctor needs to have as an income. This is also something we have to have in mind when we know what is chosen in the treatment of the patient. What do we really know at Phlebology? We have literally no long-term randomized studies to stripping, which was 100 years the only method to treat varicose veins, until the new methods arose. Nobody compared stripping with doing nothing. We have no evolution study of varicose veins from the very beginning, from C1. So we don't know if a patient has a spider or has a tributary that's visible, possibly fed by a saphenous vein. But we have no idea how long it takes this patient to get to have edema. The only thing we know is when, for example, in England, the healthcare system only reimburses treatment starting with edema. If you put a patient on a waiting list with edema and he has to wait 3-4 years, this edema will have an evolution to further stages. Because we know that in this moment when you start having edema, the compensatory mechanisms of the body against this reflux has been broken by the varicose veins. So from the moment the compensatory mechanisms have been broken and you develop symptoms, then you have an evolutivity. But we don't know how long it takes from a spider, from a visible tributary to this stage of breaking the healthy defenses against these varicose veins. We have no studies comparing wait and see for non-symptomatic varicose veins with doing something. Nobody has randomized people at 20 years old with spiders and say, okay, we will have a look. What happens if we do nothing? And what happens if we treat early? Nobody knows this. All the studies we have done after the upcoming of endoluminal treatments with long-term observation has now results of methods we do not longer apply. If you remember, when we started doing endoluminal treatment, we had a wavelength we don't use anymore in laser. We had fibers with bare fibers and not radial fibers we don't use anymore in laser. But the long-term effects, 10 years, 15 years after starting the studies, are now with those devices we no longer use because we are convinced and we have demonstrated on the short term that the newer devices are better. So even in these new methods, we don't have any long-term results with the things we currently are doing. So let me say that we are really trying to do our best, but we don't have the evidence that we are doing the best. And how do we know which is the best thing? We could do Cochrane reviews. Okay, we have Cochrane reviews to some methods. There is a Cochrane review. I mean, a Cochrane review is an analysis, a meta-analysis done by real, very standardized methods. When you have more than 2 randomized studies for one procedure, you can request a Cochrane review. And there are little Cochrane reviews because there are really little randomized controlled studies in phlebology that would be comparable. And those we have, we do ignore because they are not politically interesting. Perhaps you know that I come from the Chiva group, which is a type of surgery where you tend to preserve the saphenous vein. You just close it at very specific points to avoid the reflux to enter the vein, because we could demonstrate after 35 years of Chiva on the world that the saphenous vein reduce their caliber, they recover. And why do you have to need to turn out something or to destroy something that could recover? And so we started doing studies about Chiva in the 90s, and we have randomized controlled studies reimbursed by governments, not by any industry. And this was subject to a Cochrane review, which demonstrated that Chiva has less pain, equal first moment results, and less recurrence rate on the long term. But you know, in the industrialized countries, the reimbursement for this method is so little that nobody applies it, even though we know through Cochrane reviews that it would be the best method. So I ask myself, why do we pretend to act with evidence-based medicine if we then don't do it? We have other statistical instruments which are also ignored. Sometimes not doctors, but other persons evaluate studies and do meta-analysis from a statistical point of view. And they can correlate randomized studies and compare outcomes and recurrence rates and satisfaction of patients just from numbers point of view, not from a political point of view because they do this study to demonstrate something. They just do it to have a look what happens. And this is a systematic review and meta-analysis published in an open access published place, long-term efficacy of different procedures for treatment of varicose veins. And if you look at this graph, you have here the probability of achieving the highest satisfaction rate in the patient and the lowest recurrence rate. And of course, the higher and the more to the right, you have the best for the method. And these statistical people came to the conclusion that Chiva was the one with the highest rate in both. And nevertheless, it is still fought. China is an interesting country where the national health system has come across Chiva and is now teaching it all around the country because they base their decisions on money, on quick time to recovering, and not on the conviction of the individual doctors. So it is very interesting to observe that in China, Chiva is having like a star on the sky because people have noticed this. But in the countries where I work, I am an exot because I'm an exotic person, because I do Chiva and nobody else does. This is another thing. I don't know why we ignore these results. And if you go on, who is paying for the studies we currently see? If you go to a Phlebology Congress, you have lots of studies, this laser versus this laser, and this radiofrequency versus this acryl, all industry-pushed studies. And tell you the truth, I don't believe so much in studies performed and paid by industry. For example, the Jiva studies were paid by the healthcare system. And lots of studies around the endoluminal techniques are on the market, but with a short follow-up, and you have to look at them critically because people doing the studies are reimbursed by the industry. And I mean, lots of us have a high integrity, but some of us don't. If you then have a look at the NICE guidelines, which are very clear in the treatment of the varicose veins, you have to do endoluminal procedures, either hot, laser or endoluminal, radiofrequency, or sclerotherapy. You know, this is not because there is a large amount of studies demonstrating that this is better. This is only because it is cheaper and the return to work is more quick. This has nothing to do with medicine. This is only reimbursement, payment, putting low the price of medicine. So if somebody cites the NICE guidelines as, oh, hey, they have a good reason to do things, the reason of the NICE guidelines is financial. It's not the best for the patient. It's the best for the system. What about population studies? We have some defining the high level of incidence of venous diseases, as we also already have seen. But we have very little demonstrating a follow-up which patients will evolve without deterioration of their veins and which patients will have high evolutivity, perhaps those with a higher body weight or those with other illnesses like arterial hypertension. Who knows? We don't have any study. And I mean, this is also so because varicose veins are really highly variable. You have patients with very thin veins with a large edema and itching and so on. And you have patients with large varicose veins and they don't feel anything. So it is really difficult to stratify varicose veins. But at the end, we have to have a tool to decide. And there are pitfalls in studies. Lots of studies describe, for example, the recurrence rate after crossectomy, which is also called high ligation, stripping or not stripping the veins. And after being a member of the German guideline group for treatment of varicose veins, I asked myself, how is it possible? How is it possible that we have so different results from nearly 1-2% to over 60% recurrences after the same period of time? And I assume that people doing surgery in hospitals, in universities, doing these studies are not operating so badly that you could assume that this is due to technical errors. And I had the idea that perhaps it could be due to the suture they use. And I wrote to all these authors of the articles cited in the Medline investigation of recurrences, and I asked them what sutures they use, because they normally don't write it in the publication. They are so sure that the suture they use is of course the correct one. So one of them answered, yes, of course I use resorbable as always. If you look at this is not a meta-analysis because these studies were not developed to see the suture material. They were developed to see the recurrence rate. But if you sort them by the recurrence rate and then put colors to the sutures, you mean green are the resorbable and orange are the non-resorbable and brown are the titanium clips, which are more non-resorbable than non-resorbable threads, you see that this is an astonishing result. You have nearly no recurrences using titanium, little of them using a thread that is non-resorbable, and lots of them uses threads that are resorbable. So this little detail nobody looked at and they all were convinced mine is the correct one. You see this difference? I mean, of course you should have done a prospective randomized study comparing with the same surgeon this and this thread. But I think seeing this study is no longer necessary. It's obvious that the resorbable thread will have a higher rate of recurrences. So everybody I asked said, this is completely irrelevant which thread I use. I think it isn't. So you see, we have so many other details we have to respect and think of when we evaluate studies in medicine. And if you only took those studies with a 5 to 10 years follow-up, the thing is even more clear. If you see this, you have some short studies, only 1 or 2 years, where the thread was resorbable and the recurrence rate was little, perhaps because the recurrences come later on. But if you have only the 5 to 10 years follow-up, it is very, very clear. You had to have a cutoff. Until 12, you have non-resorbable, 12% recurrence rate. This was the group from des Maisonneuve. She used non-resorbable to close to the deep vein, across the ostial, the saphenofemoral junction, and resorbable to close the tributaries. And she's really in the between, because between two groups, and these all used resorbable threads. So the suture material influenced the outcome, and nobody thought this could be real. So definitively, if we look at studies, we are comparing apples and oranges. No conclusive data for none method. No conclusive data for progressivity. We have conclusive data if you look at the Chiva investigations for less is more. This means the less you destroy, the less the blood has to look for new ways to drain. And 80% of the tributaries disappear if you treat the great saphenous vein and do not do phlebectomies, which also provoke pain to the patients. This is demonstrated by Borsuk. So after I've told you this mess of we don't know anything really, I want to come to the concept of choosing wisely, which was developed in internal medicine. And the first question was, we have lots of lists of evidence-based statement from 80 organizations, and we try to advise clinicians, patients, and their caregivers about the optimization of care and avoiding unnecessary medical treatment and testing through this Choosing Wisely campaign. The mission they give themselves on their webpage is, we promote conversation between clinicians and patients by helping patients to choose care that is supported by evidence. I know this is not so good in phlebology, not to duplicate other tests, not to repeat everything 5 times, free from harm or as free as possible, and truly necessary. So if a patient comes to me and asks me, this was really often the case in the corona situation, Dr. Mendoza, is it really necessary for me to have this vein treated? I had to answer, no, it is not necessary to have this vein treated. You can wait some years, because apart from the situation with an ulceration or a skin discoloration, no patient has truly necessary treatment of the saphenous vein. They can wear stockings, they can have long walks, and they can wait and see. I'm sure of that. And nobody can demonstrate to me the opposite. So the first step of this group was to publish in the New England Journal of Medicine by Howard Brody, who was the promoter of this idea, an article of medicine's ethical responsibility for healthcare reform, the top 5 list. And we also have a list of choosing wisely in phlebology, because the French Society of Phlebology put a group together and gave indications to the treatment of incompetent saphenous veins and recurrences with chemical, this means sclerotherapy, and thermal ablation. And they made it very clear when to do what and which criteria you should apply to offer the patients for a discussion. So the topic is, you have to harm the least, treat with the minimal pain for patients, meet patients' own criteria, not the doctor's one. This means some patients are suffering because the spider is horrible. Of course, you have to offer him a sclerotherapy. But some patients come because they have pain in the calf when they stand because the leg is growing with edema. And they have to go back to work after the very short time. So why giving him pain, taking out all the tributary, if it is demonstrated that closing the reflux point, you may do it with laser on the saphenous vein, you may do it with short stripping, you may do it with a just crossectomy or high ligation under the correct criteria after a good duplex ultrasound to see where the reflux comes from. But then you can choose to make the minimal harm. You can just close the point where the system is fed by blood from the deep vein to the superficial one and do nothing more, because this patient has no cosmetical complaint. This patient wants to be free of pain and go back to work tomorrow. And you can give this to him even though you are earning less money for that. And this is the point where we have to come to. We have to know all the methods that are possible, even those we don't apply. And we have to know very well which methods we are good at and which ones not. And we have to search for somebody to make a bigger team and to give him the patients we can't treat. We have to be honest with the patient. We have to tell them what we know, what we can do, and what somebody else will do for them. And we have to take the time with the patient, the time which is normally not reimbursed. In Germany, at least, they have taken away any reimbursement for talking with the patient. And this is horrible, because patients have visits with their general practitioners 2 minutes, with the orthopedics 3 minutes, in, out. Nobody has asked nothing. Nobody knows which medicaments they take. What are their wishes? What are their feelings? I take at least 15 to 20 minutes just to get an idea of what is happening. And then with the patient, I make a plan. Of course I'm not reimbursed for that. And this is horrible in Germany. But I was educated like this in Spain, where I come from. And I can't do any other kind of medicine. And I think it is the right of the patient to be heard and to know and talk to the doctor and to express what he wants. And we have to listen, and we have to give him our knowledge and our care and be honest and empathic with him. And this is hard work because we are not educated in this and we have so little data. But we have experience and we can share our experience with the patient. So this is my vision of choosing wisely, and I hope to move the world's vision and comprehension on the fact that we are not the owners of the wisdom, and we have to find the way to treat this very long-lasting illness, because you can't make a varicose vein disappear forever. You just can treat it and help the patient for a while, and when it recurs, you have to treat it again and help the patient again for a while. And thus, perhaps to start treating the latest as possible, you will have at least less treatments for him. So coming to an end, again, thank you so much for this great opportunity. I hope I have opened some ideas about what we do know and what we don't know, and when it is important to treat somebody. And I'm sure that in your country, this is much more important to have another focus, because you have other problems than we here. So I try to give you my position, and I'm very happy to have discussions now about the topic, and perhaps you discuss it in your working groups. And again, the invitation, 28 September we start, and Thursday to Saturday we have English sessions, and you are very, very welcome to participate. Thank you for listening. I send you all my best wishes and blessings, and the best for your health, for your families, and for everybody. Thank you for this occasion. Bye.